Now I want to move into talking a bit, moving off of informed consent concerns, talking about boundary issues some. And again, kind of circling back, there's some of this that will be a little bit about online, but mostly not. And I think, just a reminder of the basics that all of you are familiar with, that the boundaries continue to be a debated idea, and how firm those boundaries need to be is also something that is the subject of quite a bit of conversation in our field. The idea is one about how we use or abuse our power, and then how close or how distant we are from clients, and that intimacy-distance continuum. It also is about kind of basic professional standards. What are the outer limits, for example, sexual improprieties and so forth. Clearly, of course, our professions make it illegal and unethical to engage in sexual intimacies with clients. It's classified generally as abuse or exploitation. As most of you know, there are a number of laws that have been passed in California and elsewhere to make it not only unprofessional conduct the source of a lawsuit, in addition to being unprofessional conduct, but also potentially either a misdemeanor or a felony in California. So it's no small thing to engage in sexual misconduct with a client. But short of those kind of extreme boundaries, as I was mentioning earlier, boundary ideas are somewhat flexible. There isn't a hard and fast, well, one never does this, one always does that, in many circumstances. In some, that's pretty clear, but in many. And Tom Goodheil and Glenn Gabbard, about 20 years ago, made a distinction that I think continues to be useful today. And they talk about the difference between boundary crossings and boundary violations. And their main distinction is boundary crossings are stepping over the usual boundaries in a professional relationship in a manner that's not harmful to clients or may even be beneficial. Okay? It might be accepting a gift from a 6-year-old child. The normal boundary may be that you don't accept gifts or give them, but in crossing that particular boundary, it may be beneficial, not harmful. Boundary violations are ones that they define as harmful. And reasonable distinction, but how do we tell the difference beforehand? That's the trick. How do we kind of analyze the situation and think through whether something will be a benign, or at least something that's not harmful, boundary crossing versus a boundary violation? And some of the criteria that have been described in the literature and in ethics codes are, we want to ask the question, whenever we're considering a boundary crossing, stepping over a boundary, whether it might undermine our reasonable objectivity or judgment, whether it could compromise our primary role as a provider, or whether it might be viewed as potentially exploitative of a client. Okay? And if the answer to all three of these is no, then the general sense is one may proceed. But even though these, it's funny, when I read these particular standards, when I think about the asking those questions, they're great questions, but they're also not easy to answer. So, Pat, if you were to ask me, well, will this compromise your primary role as a provider? There may be a more or less knee-jerk reaction to say, well, no, I can maintain my good boundaries with clients, and I won't let this affect things. But it's frequently not that easy. And so actually having kind of an exploring conversation about these things, these three questions, are important. It can be really difficult to determine risks in crossing of boundaries. And there are, interestingly enough, at least anecdotal descriptions in the literature about situations that are problematic in terms of boundary crossings. And I'd like to describe a couple to you. The ones I'm going to use are from Tom Goodheil's 2005 article in the Journal of the American Academy of Psychiatry and Law, where he talks about, it's an article called Boundaries, Blackmail, and Double Binds. Kind of a provocative title. And he gives a number of examples. I'm just going to give you two, and then talk a little bit about the similarities and some of the recommendations Dr. Goodheil gives. He gives what he calls his example 4. He says, an intelligent and articulate patient repeatedly complained of intense difficulty with separation from the therapist and failures of object constancy between sessions, such that therapy might not be able to continue. Among an extensive series of boundary transgressions, to deal with the problem of separation and real intense difficulty, and to keep the client in therapy, the therapist gave the patient a shirt he had worn so that she could keep it on her pillow at night and fall asleep smelling the therapist. This action became part of a later complaint which the patient brought when the therapist had retracted a boundary crossing, that is, a promise to come to the patient's home in the evenings after therapy was over, under the advice from risk management. And the patient stated, I didn't know who he was anymore. Okay. So one of the tricky things was the gift. Now the gift was an interesting and kind of very intimate gift, which carries a really different connotation and emotional tone to it than giving somebody a card or something that's relatively professional in nature. You can imagine giving somebody one of your shirts. So that's one example. The second example that I want to use, and this is on page 477, 478 of his article. In a similar situation, a female counselor was working with an extremely difficult female patient with borderline personality disorder and possible dissociative identity disorder, who was also a severe self-mutilator. So a person who was really, really in a lot of distress and very kind of at a high risk. The patient had had a long experience in various therapies. She had several extreme sensitivities based on her abuse history. They included an intense need for privacy. This encompassed not wanting certain things to be written down in the notes, resisting the therapist's supervision or consultation about the case, and threatening self-mutilation when her desires were thwarted. The counselor attempted to navigate this minefield of traumatic associations by crossing multiple boundaries in the form of many phone calls outside of business hours, home visits, and exchange of very personal cards and letters. No shirts. On one occasion, the patient took the counselor's hand and attempted to place the counselor's hand on the patient's own breast. The counselor allegedly interrupted the attempt before contact. This act was later presented as, quote, she touched my breast, unquote. After much treatment for trauma-related bodily numbness, the patient began for the first time to feel physical sensations in the office, and she began to masturbate. The counselor felt utterly trapped and held hostage in a double bind. To stay in the room would be to participate passively. To leave and get consultation or have someone come in would be, she feared, to trigger severe self-mutilation, as had occurred before when some aspect of past abuse, such as invasion of privacy, was symbolically repeated. When, after reflection, the therapist refused a particular boundary crossing, the patient called the counselor's clinic and brought a complaint. When the clinic and counselor went into complaint mode and began to investigate the matter, including having someone sit in on the therapy, the patient protested that she had not brought any complaint. Rather, one of her alters had, and she complained bitterly about the measures designed to protect her from alleged misconduct. The patient, however, later did file a complaint filled with allegations of sexual behavior, much of it implausible, by the therapist. In a subsequent board complaint, all the patients allegedly requested responses in the form of boundary crossings. That is, the therapist has said that the patient asked for all the things that happened. Well, these were all then framed or presented as though they'd been initiated by the therapist for the therapist's own needs. So these cases, and actually the remainder of the other 4 cases that Tom Goodheil writes about, have some interesting similarities. The one similarity is they started with a slippery slope of kind of benign, although I don't know about a shirt, but a card or a letter, benign boundary crossings. Doesn't mean they were wrong or bad, but they were benign boundary crossings with high functioning, or what appeared to be high functioning people with some fairly severe personality disorders. And the boundary crossings were in the context, as Goodheil talks about, of trying to help the person stay in treatment. So there was kind of a subtext. The reason he uses the term blackmail was the emotional blackmail of I will leave therapy or I will hurt myself if you act according to the usual boundaries that occur in a psychotherapeutic relationship. And as a result of, and most of these cases have a similar flavor, although these were not, by the way, the only really outrageous cases. So these were 2 of 6. These were clients with personality disorders, high and low functioning. And those are not the only clients, but as many of you know, such clients can really push boundaries. They can push for boundary crossings. And it's very tempting to cross those boundaries, in part because one is attempting to repair previous injuries. So there's a pull to try to do what one can. I don't think the therapist or the clients, by the way, and I didn't write that, but I think it's true, started this out with bad intent. I do think that as problems started to emerge, what happened was innocuous boundary crossings began to be at least presented as serious boundary violations by the therapists. Going to people's homes who are in private practice or in your clinic, calling them after hours, that's beginning to step into territory that's pretty risky unless you're somebody who's doing home visitation and, in-home family therapy or child therapy. If it's not structured that way, it would concern me. Interestingly, and although this was in 2005, there's been, during this past decade, lots and lots of conversation with a real push in the field to loosen up boundaries. So I've been quoting Ofer Zur earlier about some of the cyber blurring issues, and Ofer is one of the proponents for loosening boundaries, and believes that that engaging in other activities with clients is not only permissible but sometimes very helpful, and that coming from a more behavioral or cognitive behavioral perspective, boundary ideas may not be all that helpful. But Tom comes from the opposite direction. He actually was arguing, and I am in agreement here, that it's important to be really clear about boundaries at the outset and then stick to them throughout the course of treatment. If I don't say, well, I'll never accept a gift, I don't have to stick to that. But I want to be really careful about what kind of gifts I do accept if I'm going to accept them. Or if a client asks if they can take, a picture that they drew with them, to have that be a kind of something that I consider carefully and talk about with colleagues as well as clients. He wasn't arguing, and he was in fact saying, as you can see from the quote from page 480, even theoretically benign boundary crossings can be misconstrued or portrayed in a worse light in later litigation. Boundary crossings thus require circumspection, weighing of pros and cons, and obtaining consultation with a low threshold. I want to highlight something here. They can be misconstrued. I actually think that's what happened in these cases. I don't think the client started out with this intent of getting the therapist, even though it can very much feel that way as things progress and get worse and worse. I think what happened was they really understood and experienced the boundary crossings in a different way than the therapist intended them. And as you all know, the problem is we often do not know how people experience our interventions. Even if we regularly check in with them, they manage our impressions of them. That's kind of what happens in treatment. This is, in my view, an interesting suggestion in this era of kind of increased, I wouldn't quite go laxity, but consideration of where boundaries might be bendable. I'm struck with, and it may be because when folks consult with me, it's often because bad things are beginning to happen, and boundary crossings are now boundary violations, or they're near there. But I hear many stories like the ones that Tom Goodheil wrote about. And they are from colleagues who I respect. They're from colleagues who are doing their best and really care about the clients they're working with. And they begin with small things. So I'm not telling you forget boundary crossings, but I am saying this whole idea of circumspection, really considering them pros and cons, and then making sure that you talk with colleagues about what bad things might happen, but also what potential benefits, and are there any ways to minimize the potential harm. Okay? This is, again, low threshold, as Tom Goodheil says, low threshold for consultation. Fortunately, it is a very, very small minority of therapists who violate sexual boundary norms. Roughly somewhere between 3 and 6 a year in the past 8 years or 10 years in California have had their licenses disciplined for that. That's a small number. It's still too high a number in my view. The same rules that underlie the reasons for setting boundaries around sexual intimacies, the same principles and theoretical considerations underlie why we have to be careful about other boundaries. It's about the fact that there is a power differential, that there's also a differential in terms of mutuality and self-disclosure, and there is an asymmetry in the nature of the relationship in terms of who gets attention for what. And those create a differential that as Sorensa, who's an analyst in Boston, talks about, those create a situation where a client, by their role, is supposed to be vulnerable, more vulnerable than the therapist in the relationship. And by virtue of that emotional vulnerability, that's what gives us the additional duty to protect that vulnerability and not act in ways that might compromise the person. This notion of a special relationship that I was just mentioning and vulnerability and asymmetry it's similar across different types of boundary crossings. And perhaps it's just I'm getting a little older, but I really believe that, thank you, Joe, I really believe that, that it's very important to consider when you are thinking about engaging in a boundary crossing to slow down. And client comes in like that, and you say, this is so interesting. Well, I certainly won't hate you, but I need to think and talk about this. I don't know if I can work under the conditions of having to continually make exceptions. Where does this stop? And so let me think about that. And maybe I'll either need to refer you, although, this is one of those referrals where I might say, anybody who I send you to, who I trust and respect, is going to say the same thing I do. So, Houston, we have a problem. I'm sure all of us have had clients at one time or another who they could not hear, or hearing something like that just didn't compute. It was not something about which they could make emotional sense. Again, I think of this as being about safety and about a controlled and reasonably expectable environment for clients. As many of you know, folks, for example, who are diagnosed with borderline personality disorder often have trauma in their histories. And if they don't, they have very erratic parenting experiences. They also might temperamentally have much more difficulty regulating affect. And so, as a result of all three of those things, when we cross boundaries, the meaning of that gets much magnified as compared to someone, like a person you're working with who's struggling with an isolated issue and does not carry all of that history and all of that temperamental compromise.